We're going to be at like 100 degrees today and tomorrow. Not quite 100 today, but tomorrow we are supposed to hit it.
Oh, wow.
Oh
Is
no.
it, do you have a cool breeze? Is it humid at all? Like, is it a
Oh,
pleasant
not humid.
100?
It's a dry heat.
Oh, that's good for curly hair.
What does that do? Does it make it straight or no?
No, it just doesn't make it frizz as bad. Like here in Texas, I'm constantly battling the frizz.
Oh no,
So,
because
yeah,
it's humid.
yeah.
Yeah.
Like no matter how much product you put in the hair, it just frizzes. So you just don't fight the beast.
Oh, I see.
I know that, Madeline, all too well. Yes.
Yeah. If you
No, I
fight
have
it,
it,
hair
it's like,
out
why?
to here when I go to Texas. That's why you'll always see me in a ponytail in Texas
yep,
Yeah.
I understand.
or a
Yeah.
bun or whatever.
Yeah, curly hair has a mind of its own. And so the more you mess with it, the more it rears its head. So less is best.
Can you just let it go and be frizzy and look like a 80s aerobics instructor or something?
That's
With the
fun, right?
headband
With the
or
headband.
yeah.
I would nail that part if we had that
Yeah, you're not
competition for sure.
you're not that old to know about those guys.
Well,
Mm.
I remember me some Richard Simmons and Denise Austin and all those good
Yeah.
workout
Jane
workout
Fonda.
folks. Jane
Yeah.
Fonda, yeah, all those good folks.
Remember Suzanne Summers? She had that like thigh master thing.
Mm-hmm.
Yeah.
Yeah, fun stuff.
We have a lot of folks in Texas this week. Isn't there something going on, Liz? I thought like Kara's in Texas, right?
Yeah, she went there yesterday, and like Katie Galley, and they're working on the RFP.
Or New Mexico? No, Texas.
No,
Oh,
Texas.
yeah.
It's
Oh,
June,
yeah.
July 11th.
Oh, okay, that's right. Okay. There's always something going on.
Exactly.
Mm-hmm.
And then implementation for New Mexico, like the 7-1s, like
Turquoise
the
care.
yep. So
The
lots,
guiding
lots
care and
going on.
turquoise care.
Oh yeah,
Oh,
that
gosh.
too. Oh my gosh.
Yeah.
I mean, it's not a huge deal of switching over to turquoise care. We have a few things that have to be implemented, but we actually have time for them.
Mm-hmm.
We don't have to do everything we promised right away.
Well, we already did it for Texas, so it should be easy, I'm hoping. The New Mexico one. Isn't it? We've already kind of done it with Texas.
For
so I'm
guiding
hoping-
care?
Yeah.
Well, it's about 6 times the size of
Oh,
Texas.
well, there is that. Yeah. Oh, well.
Like, there's literally been 3 cases of guiding care that have gone through for BH right now for Texas. I
Oh,
did
for-
2, and Smitha
Gotcha.
got the other one.
Wow.
So, yeah, we won't have the luxury of as much time. So,
Yeah.
but I think it'll become old hat.
Yeah, I hear you.
Hey, good morning, everyone, and welcome to our webinar this morning. The topic is on trauma-informed and trauma-responsive care. This training is being offered by the Behavioral Health Clinical Operations Department, Behavioral Health Quality Department, and Behavioral Health Medical Directors. Today's training will be led by Dr. Tom Allen and Dr. Brooke Parrish. If you have any questions for the presenters, there'll be time at the very end for questions, and you're welcome to type your questions in the Q&A box. All right, Dr. Allen, I will pass it to you.
Thank you, Madeline. Good morning, everybody. I'm Tom Allen, Executive Medical Director of Behavioral Health at Healthcare Service Corporation, and I'm joined by Dr. Brooke Parrish, who's also an Executive Medical Director of Behavioral Health at Healthcare Service Corporation. I'm a psychiatrist by training, and Dr. Parrish is both a psychiatrist and an internist. And we are excited to talk with you today about trauma-informed and trauma-responsive care. Next slide, please. Here are some of our disclosures. Next slide. All right, so an overview of this morning. First, we'll define what trauma is, and then we'll look at some principles and approaches for trauma-informed care. We'll talk about how to support a patient with a trauma history, and then look at some screening tools. Next slide. And next slide, please. So, how to define trauma? And the next few slides are going to cover the following areas. First is what is a definition of trauma, and specifically we'll get into adverse childhood experiences. Next, we'll look at the different types of trauma, especially those that occur during developmental stages of our lives. We'll look at some of the responses we have to trauma, and then some downstream physical and emotional and behavioral manifestations of trauma, specifically how those could lead to substance use disorders. Next slide. So in terms of defining trauma, I like to think of it as three parts. It's essentially the three E's. There's first an event, and then there's an experience of that event, and then there's an effect. And so these experiences cause intense physical and psychological stress reactions. But first, the triggering event typically is something that's life-threatening in nature. The experience of that event is usually influenced by multiple different factors, more on a kind of an individual level. Those have to do with how do we interpret the event, and whether we feel in control or not, what kind of social or supports we have externally, and also what kind of coping skills and resilience we have. And those, depending on how we experience the event, it could lead to certain effects. And those effects are generally both physical and psychological. So some of the physical stress reactions, things that we've talked about or we know about previously, those are the fight or flight kind of reactions. And this allows us to kind of avoid a threat and be safe. And it includes things like increased blood pressure, heart rate, breathing, tightening of muscles. So we feel this when we're anxious. And then we also have psychological stress reactions. Those could be more cognitive or emotional. It's difficulty concentrating, feeling overwhelmed, worrying, difficulty making decisions, or forgetful. And often the trauma can kind of come and go, and people have these reactions, and then they calm down, and we're back to baseline. Or it can cause a persistent, lasting stress response that can affect people later in life. It's kind of always feeling on edge, for example. So in summary, just to kind of define trauma, it results from an event, a series of events or set of circumstances that's experienced by an individual as physically or emotionally harmful or threatening, and may have lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. Next slide, please. So I'm going to go over 3 different types of trauma, or 3 different categories. First is an acute trauma that we'll talk about now, and then we'll talk a little bit later about chronic trauma and complex trauma. So acute trauma is essentially kind of like a one and done sort of thing. It's a singular event that's narrow and brief, or narrow in focus and brief. But it can lead to traumatic shock. So depending on the severity of it, people can have the reactions that we talked about previously, you know, the physical and psychological reactions. And those can include accidents, falls, near drowning experiences, assault or violence, acts of war or terrorism, violence in the community, natural disasters or emergency medical procedures. And these are really, you know, life-threatening events. And sometimes these traumatic events happen repeatedly over time, and have a cumulative effect on our lives. And that can cause something called chronic trauma. So it's not a one and done, but it's a repeated or multiple different events that occur in our lives. And those can cause a sustained traumatic stress response that remains activated even after the initial incident has gone away. Next slide, please. And now we're going to talk about the third category of trauma, which is complex trauma. And one example of this is adverse childhood experiences, or ACEs. And these are particularly problematic because they occur when our brains are developing as children or adolescents, so between the ages of about 1 to 17 years old. And you know, this could include things like, you know, physical, sexual, or emotional abuse, poverty, racism, discrimination, oppression, childhood neglect, loss of a parent or a loved one at an early age, exposure to domestic violence. And this is significant because even though the violence isn't targeted toward the person, you know, children depend on their parents as their caregivers for their own safety. And if we see our parent being abused, we worry about our safety, and it could have that life-threatening effect that we talked about previously. So exposure to parental drug abuse, parental mental illness, and prenatal and perinatal trauma. And so what's significant about this is that excessive activation of the stress response in our brain, and we're going to go over a little bit about the neurobiology of that in a minute, but that can cause, that can affect the developing brain in adverse ways. It can actually be toxic to a developing brain and cause, you know, significant downstream effects as the person gets older. So, for example, the adverse childhood experiences are also called relational trauma, because the person who the parent or caregiver is essentially the cause of the traumatic stress, abuse, or neglect in early childhood. And that's the person who's really there, who's supposed to be our primary caregiver. So not only does it cause, you know, increased vulnerability or fear of our lives in a way, which is essentially unconscious because we're not often aware of that, but it can also take away that important source of soothing in our lives. You know, we learn how to soothe ourselves as adults primarily through what we experience as children with our parents. So without that parental source of soothing, you know, everything's going to be okay kind of thing, we're not able to do that for ourselves later in life. And as a result, we can live in kind of a conscious or unconscious state of, you know, fear, alarm, depression, or dissociation. Next slide, please. So what are some trauma responses? And many of you have heard of these before: the fight, flight, freeze, or fawn response. The fight response is, you know, all of this is essentially from the heightened sympathetic nervous system. So we feel combative, aggressive, reactive, defensive. We're ready to fight. Flight is we want to run away. We want to remove oneself. We want to remove ourselves from the situation. Freeze is shutting down, feeling numb, dissociating. And fawn is befriending, so becoming excessively people pleasing, overly polite, obedient, and trying to avoid conflict. And the reason this is important is in the clinical setting, we see people who present with these different sorts of qualities. And they can be sometimes problematic in not only forming that therapeutic alliance, but also, them following through with recommendations, or, some of these characteristics can cause them problems in their lives, personally, but also interpersonally. And what one way to understand this, and I'm going to go a little bit off slide for a second, is to describe what happens in our brain when there is a traumatic experience. So there's three parts of our brain that help to process stress. And one is the amygdala, which is a small part inside of our brain in the limbic system that helps to process emotions. So especially, fear, anxiety. And when we have a fear response, that's the part of our brain that lights up, that kind of goes into overdrive. And then we have two other parts, the hippocampus, which is on the side of our head, and our temporal lobes. Those help provide memory, so we can learn from these experiences, and also it helps to tamper the effects over time. And then the prefrontal cortex in the front of our brains, those are kind of the highest cognitive functioning. It's where we do a lot of our thinking, problem solving. We can regulate our emotions. It's what gives us that kind of rational, think rationally about this and don't just react. The problem with early childhood trauma is it causes the amygdala to go into overdrive, and that overdrive of the amygdala can actually be damaging to the hippocampus and the prefrontal cortex. So they lose their volume, they lose their neural connectivity, they don't work as well. And so you end up with a person who's kind of quick to respond and feeling always on edge without that buffering of those other parts of the brain. They can't calm themselves down. And so as a result, we'll see these trauma responses in people who have early traumatic experiences while their brain is developing. Next slide, please. So what are some manifestations of trauma in terms of physical health? Well, you think of somebody who's having excessive brain activity, excessive fear response. Sometimes they can be a little more impulsive. This can lead to self-medicating with substances, for example. So alcohol, drugs, tobacco. Often people with early childhood experiences, there's a higher risk for substance use, and particularly tobacco use. And then we see higher instances of chronic obstructive pulmonary disease in people with tobacco use. So they're higher risk for that. Chronic pain, the emotional pain is sometimes experienced as physical pain, and it can exacerbate underlying pain conditions. Stroke or cardiovascular issues. We know that with the increased sympathetic nervous system, this can cause heightened blood pressure, pulse. It can also cause increased inflammation, vascular damage, and that can lead to heart attacks, strokes. Migraines, severe headaches can be a consequence, GI issues, sleep disturbances, urological problems like, in children, for example, they have nighttime urination, bedwetting, overactive bladder, muscle tension, and then metabolic. In addition to what we talked about before, it can affect insulin resistance, put somebody at higher risk for diabetes. It can cause obesity because of the increased stress response stress hormones, cortisol. It can also interfere with our ability to fight infections. And also increased inflammation can cause us to feel sluggish. It can, cause us to feel foggy in our thinking, but also can have effects on our, on our vasculature again, which could lead us to higher risks for heart disease and strokes, but also dementia later in life. Next slide, please. And what are some manifestations of trauma in terms of mental health? Certainly anxiety and depression for the reasons we talked about before. PTSD, which is hypervigilance, always looking over your shoulder, the re-experiencing, the nightmares, flashbacks, and also the emotional numbing or the avoidance. We want to just kind of isolate. And that can cause problems with functioning, obviously. Severe difficulties in relationships with others, the functioning impairments in social, occupational, and academic settings, drug and alcohol and tobacco use or addiction, which we talked about before, prescription medication misuse, suicidality. So a lot of the trauma can lead to, not feeling comfortable in one's own skin, feeling very empty. Also, sexual trauma can be a high risk for that, and also combat-related trauma, which we see in veterans, high risk for suicidality. Self-harm, often as a way to help to modulate some of those emotions. It can be a coping skill for some people. It can be harmful, but for some people, it's a coping skill. And disordered eating. A lot of the trauma can affect how we see ourselves. It can cause body image issues, but also eating, restricting and overeating can be coping skills as well for some people dealing with stress. And then somatic complaints as well. We talked about how psychological symptoms can manifest in physical symptoms. Next slide, please. And then just to circle back on trauma and substance use, certain traumatic events, conditions, circumstances can increase one's vulnerability to substance use. And that could be alcohol, tobacco, illegal substances, prescription medications. Traumatic events, particularly childhood experiences, have higher risk for substance use. Also the development of PTSD symptoms, that kind of wanting to get rid of or numb or self-medicate those uncomfortable symptoms. Certainly things like poverty can be a risk factor and lead to increased stress, which can be traumatic, the kind of the cumulative trauma for people. And then also it could lead to increased risk-taking behaviors. So, we talked about how the overactive amygdala and that inability to self-soothe can lead to kind of impulsivity and people taking more risks. They don't have that prefrontal cortex activities sufficiently able to modulate their emotions and behaviors. So higher incidence of risk-taking behaviors. And this could also be a part of substance use, can be related to that as well. Next slide, please. And I will pass this over to Dr. Parrish to talk about trauma-informed care.
Thank you so much, Tom. Now I'm going to go into a little bit of trauma-informed care in terms of both healthcare entity and for clinicians. Next slide, please. Are folks hearing me? There we go. Thank you. If you make the leap into trauma-informed care, there is a certain investment that you do have to make, both in terms of training and perhaps even into changing your physical layout. So what are the benefits of trauma-informed care? Why do you want to make this investment? It really can have a overall beneficial, both in terms of financial, along with in terms of patient and in terms of staff, provider, wellness and being. One is patient engagement. If the patients feel safe in coming to you, they will continue to come to you as opposed to very sporadically um, arriving and coming. In terms of health outcomes, again, you'll have much better compliance with that feeling safe, feeling that they were engaged in making the choices that they're making in terms for their health. We as providers and often people that are attracted into the healthcare field tend to have our own trauma backgrounds. Not everybody, but a lot of us. And so, again, having that safe space and having that trauma informed care as an organizational level will provide for better staff and provider wellness, um, and certainly lead to lower staff turnover, which we've certainly seen a lot of in recent times with our healthcare workforce. Also, a decrease in unnecessarily utilization, especially in the higher levels of care. Again, when you have somebody that is more compliant, you're going to not see people going into the ED or into some of the higher levels of care and being able to be managed at a much lower level of care. So these are sort of all the benefits of really changing that perspective over of why do you act this way to what happened to you. Next slide. So implementation, again, it must really incorporate both that clinical practice and that organizational practice. Sandra Bloom basically said trying to implement trauma-specific clinical practices without implementing trauma-informed organizational cultural change is like throwing seeds on a dry land. Next slide. So what are the core principles of trauma-informed approach to care? One is patient empowerment, really using what that individual's strengths are so that they take ownership of their own health and develop their treatment plan and really become engaged into implementing their treatment plan. Choice, again, we know this as informed consent, but really informing patients of every episode of what is the risk, benefits, indications, and alternatives to any treatment for treating whatever condition that they may have. And again, that collaboration, both with the patient, but also with that other healthcare staff, so that everybody is really on the same page in terms of that treatment plan of how is that patient going to manage their own health. Also involving the families if it is appropriate, and really having that organizational change of really looking at trauma-informed care and creating that treatment plan. Safety, and again, developing a healthcare setting that really ensures not only their physical safety, but their emotional safety as well. And Dr. Allen's going to talk a little bit more about nuts and bolts in a minute about how we can create some of that safetiness. And again, trustworthiness, really creating those clear expectations with patients of what the treatments entail and who will provide those services and how that care will be provided. And again, sort of having patients so that this care is happening with them and not to them. Next slide. So organizational, how do we create that organizational? Again, sort of that organizational with the clinical. Well, one is sort of leading in communications about the transformation process. If you're going to make a cultural change, you really have to become sort of that master of change processes and communicate what we're doing and why. That it is better for us as an organization and it is better for the patients. Again, engaging patients in organizational planning, having those that are going to be the end result of receiving and helping participate in this care. Let them give feedback. Some experts actually suggest that you hire patients as consultants in terms of this new organizational change and keeping them on. as that consultant. Training clinical as well as the non-clinical staff members. Remember, patients don't just interact with the providers. They also interact with the security guards, the front receptionist. All of them must also be trained in trauma-informed care. And again, creating that safe environment, be it both emotional in terms of that welcoming and that physical plant. Preventing secondary traumatic stress in staff. Again, remember that the healthcare providers and those that are attracted to healthcare, even if they're not a clinical member of the clinical staff, can have their own traumatic experiences that they're coming into it. And so preventing that secondary traumatic stress in staff, given that they may be hearing things that could be triggering to them. So making sure that they also are safe. And again, hiring a trauma-informed workforce. Does that mean that your workforce, before they get hired, need to have gone through all this trauma-informed training? No, but looking at an interviewing patient, and it's basically the behavioral-based interviewing of how did you handle past situations like that? So somebody that's working as a receptionist, they used to be in retail, asking them questions about perhaps how they handled different situations. Next slide, please. And in terms of creating a trauma-informed approach for the clinical, one is really involving patients in that treatment process, really helping them make those informed decisions of what will be best for them in terms of informed consent. 2, screening for trauma. And we're going to go a little bit into some of the screening instruments that are available, and available actually for free and public use. And again, training the staff in trauma-specific treatment approaches, and we'll go into some of the trauma-specific treatment approaches. And then engaging referral sources and partnering organizations. If you're a primary care provider, you're not expected to actually provide all this different treatment in terms of cognitive behavioral, but who are those referral sources that you want to refer to? And are they trauma specific also, or trauma informed? Next slide. And again, that patient experience of really looking at that individual, both interpersonal and collective, in terms of patient experiences for your organization. So examples that trauma can cause for that individual, that lack of privacy, being touched, having medical procedures done to them, different positions of that are needed during a medical procedure. Basically, also in terms of for surgery, fear of waking during surgery and experiencing that pain, loss of control that's absolutely inherent in a lot of surgical procedures. So we're looking at that and helping them understand and make that conscious choice in terms of what all is going to happen to them while they are under anesthesia. Interpersonal, again, that physical touch that often needs to happen during medical caregiving, the procedures. These are not routine. Most people, even something that is simple as a blood draw or putting in an IV, this is not an everyday occurrence for most folks. And so really talking them through it of what's going to happen. Again, being unsure what's going to happen to them during surgery. So really helping them understand, again, fear of surgical mistakes, confirmation of a diagnosis with a poor prognosis. And again, collectively, the fact that we have psychological reactions to a traumatic event that can really affect both society and as a group. And I give really two examples with this. One is one that we've all been through in the past couple of years, and that is, of course, the pandemic. The other, of course, is sort of the fear in terms of gun violence. We have looking at gun violence as a society. This used to be much, much lower. It has increased thousands of percent between in the last basically 10 years. Next slide, please. All right, Tom, I'm going to turn it over to you for a few nuts and bolts in terms of supporting a patient. Thank you so much.
Thank you, Brooke. All right, so we're going to talk now about tips for supporting a patient with a trauma history. Next slide, please. So first, let's look at the physical environment. So I'm just going to go around kind of this diagram here. Keep parking lots, common areas, bathrooms, and entrances, exits well lighted, so that obviously people don't feel vulnerable or unsafe in those areas. Decorate with warm colors and artwork. Create spaces for staff to relax. So this is important, for a comforting experience, but also you want to have it comforting, as Dr. Parrish said, for the staff as well, and really be able to provide, physical space and also opportunities for them to talk with one another, give and get support, to try to mitigate the risk of some of the secondary trauma that they might experience. Ensure security guards are readily available in settings where necessary, and consider stationing them at building entrances and exits to monitor the flow of traffic in and out of the building. So extra layer of security and safety. Keep noise levels in waiting rooms low. Use positive and welcoming language on waiting room signage, and ensure people are not allowed to loiter or congregate outside entrances and exits. So kind of the big thing, and Dr. Parrish talked about this, is try to limit the degree of unpredictable experiences, or experiences that could be particularly shocking or people are not prepared for. Anything we can do to be clear and consistent in our messaging, in our instructions on how to help people feel prepared. As Dr. Parrish said, asking for their consent, making sure they're part of the decision-making process so they feel in control. All that can be very helpful in reducing the risk of re-traumatizing in a clinical setting. Next slide, please. And then some tips for creating a safe care environment, in social and emotionally. So we look at training all clinical and non-clinical staff to effectively communicate with patients. And this, one thing is, often people who are experiencing trauma or have experienced trauma, they often can be pretty overwhelmed emotionally, and it's hard for them to kind of process thoughts or think through things or concentrate. So trying to speak, clearly and easy to understand, you might have to repeat yourself or just be, supportive in your communication is helpful. As Dr. Parrish said, emphasize patient choice and autonomy, give them choices as well. And also try not to use language that could be potentially hurtful. I know we all try not to do that, but anything that could be potentially re-traumatizing. And then, encourage frontline staff or front desk staff, security guards to greet patients in a warm and welcoming manner. Understand how an individual's culture affects how they perceive trauma, safety, and privacy. Send medical forms that require patients to provide sensitive information ahead of time. So again, preparation, consistency, clarity. Ask patients whether they are comfortable with having the door shut during exams or meetings. And keep consistent schedules and offer sufficient notice and preparation when changes are necessary. And just to kind of summarize all of this, and Dr. Parrish touched on this, is, often kind of we need to use a trauma-informed lens in the way we see people. And if people are behaving certain ways that we don't understand, or we think is getting in the way of their care or our ability to work with them, a really, instead of asking, what's wrong with them, a more helpful question is, what happened to them, and try and be curious about maybe some of the upstream, or the causes, or not the causes, but the the conditions that might have led to how they're acting and how they're using certain defense mechanisms to try just to navigate day-to-day stressors. So next slide, please. And I'll turn it back to you, Dr. Parrish, for screening tools.
Excellent. Thank you so much, Dr. Allen. Next slide, please. So in terms of trauma screening, there are many public use screening tools out there that really can be helpful in terms of assessing for the level of trauma and impact onto individuals. Most of these can be very, very brief. And in terms, they're often checklists that the patients can do themselves. And again, as Tom touched off of, is perhaps even sending these pre-appointments. There is a bit of a question of when should you do screening? How much screening should you do? If you are primary care, many experts actually offer that doing universal screening, but not often, in terms of sort of doing it once and then feeling if things are necessary, being able to do it again, because you certainly don't want the screening to re-traumatize. And again, these checklists that you perhaps are doing can be sent ahead of time and again done in the privacy of their own home. It does not necessarily have to require staff participation for these tools. For behavioral health providers, you're probably going to want to do a much more in-depth assessment to really help understand what all is the trauma, and this may help inform where you want to go with your cognitive behavioral or other treatment methods, which we'll get a little bit more into. And it's really kind of important to gather some of that information in terms of those past experiences. Depending on your role in that for that patient, depends on how much in depth you need to know. But really having a knowledge that this person could be at risk for those increased risk of chronic illnesses or substance abuse due to trauma can be quite helpful. And again, that screening is one of the ways that this can bring this to light for you and help with some of that preventive medicine. The other thing also is screening for suicidality. And screening for suicidality, both there are some forms that are much more uniform, but really even asking them, have you had thoughts about harming or killing yourself? And have you ever attempted to do so can really go a long way. And certainly checking in where they are now. Are you having those feelings now? Was it recently or is it in the past? Can also help you with planning for that patient's safety. And unlike trauma screening, that perhaps should be done less frequently if you're a primary care, suicidality is one of those things that can change on a dime, and so really should be done much more frequently. Next slide, please. So some of the sampled screening tools. Stressful life experiences really goes over basically 13 items. However, it sort of digs in terms of what was their stressfulness and interpretation for that person. For an example, one of the questions is around physical force, or was a weapon used, and did anyone die, and how many perpetrators were there. So for each of those 13, they do sort of go into what was the depth of the trauma. The SPAN assessment really looks at those physiological symptoms of the arousal, anger, and numbness. And it also identifies which of those does the patient identify as most distressing. There's the primary care post-traumatic stress disorder screening, and it's 5 questions of traumatic experiences, PTSD checklist, and that is specific trauma and answers questions related to that trauma. life events checklist for DSM-5. This is 17 basic events that the patient can look at and how they have affected life. And again, the ACE experience questionnaire, adverse childhood experience. It was with the ACE questionnaire that we really started looking at and realizing how much the ACE adverse childhood experiences really affect adults in terms of their physical health, in terms of the chronic diseases. And yes, many of these chronic diseases are lifestyle choices, but all that sort of goes back into their trauma of what they are either using substances in terms of numbing or other ways that if their fear is in trauma is reenacting that prevents perhaps some of the more healthy lifestyle issues. And so the ACEs is a 10-question screening tool. And then there's a brief trauma questionnaire, again, a 10-question self-report, looking at exposure to traumatic situations and again, how that patient interprets those situations. So a little bit more into the depth, much like stressful life experiences. Next slide, please. For children up to age 19 is the pediatric ACEs and related life event screener. And then there's also the pediatric trauma stress screening tool, and that's for ages 6 to 18. In terms of looking for depression, for adolescents, much like the PHQ-9 that we use for adults, there's a PHQ-9A for adolescents. And there's also the somatic symptoms for parent and guardians, and that's for ages 6 to 17. And that was actually just adopted off of the PHQ 15 for children. Next slide, please. So comprehensive care. What all can we do in terms of care? For adults, a lot of these fall under that cognitive behavioral therapy umbrella. In fact, like cognitive processing therapy, which focuses on changing beliefs about trauma to create new understanding. In many ways, this can also fall under, again, the CBT umbrella. There's also prolonged exposure therapy, which includes such things as breathing exercises and real world practice in terms of what would happen in the real world? How are you going to handle this in the real world? And it's 8 to 15 sessions. And people have shown a 86% improvement over control groups for those that do prolonged exposure therapy. EMDR is endorsed by both the Veterans Administration and the World Health Organization. And while it has EMDR, it can also be done with tapping, tones, etc. And it's very similar in terms of exposure, other prolonged exposure therapies or other exposure therapies. And it was held out as sort of the gold standard for traumatic events. However, a meta-analysis has shown that the outcome is similar to other exposure events. And there's been a lot of work done in terms of some of the other exposure therapies that include using virtual reality and things very similar. And that can also be combined to using this tapping, tones, or eye movements to help with this. Some folks may also prefer alternative treatments, and acupuncture, yoga, and meditation all show promise for this. Another one that falls under the cognitive behavioral therapy, and again, these are all examples. You may have your own, and as long as it's evidence-based, that is all fine. And that's seeking safety. And seeking safety integrates that substance use disorder component along with a traumatic component and really works on that skill building. Next slide, please. Examples for comprehensive care also include medication. Most of them are based on the SSRIs along with the SNRIs. These are a few examples. A lot of folks, in terms of the SSRIs, prefer to use some of the sertraline or paroxetine. Both of these do tend to have a little bit more of an anticholinergic that will help in some ways with sort of that more calming aspect. Prazosin is an alpha blocker, goes by the brand name Minipress, and can be very, very helpful for nightmares. The other alpha blocker that we are quite familiar with, which is clonidine, unfortunately has not shown to be quite as effective as prazosin. Next slide, please. So PTSD and substance use disorders, I think we have mentioned this several different times. And part of the reason is really that trauma and substance use disorder, and I'm going to use this in a much broader term in terms of really any addiction. And we can see this again with the eating disorders, that really a lot of the eating disorders do have a parallel to what we traditionally think of as substance use disorder, only the substance can be food. And that includes like the binge eating disorder, bulimia, and even anorexia in terms of the body image distortion that you can see with the anorexia and other substance use disorders. Excuse me, my allergies are getting to me a little bit. And again, so those multiple, and also again, going back into like even the gambling addictions, internet addictions, and even sex addictions can all go back to a traumatic issue. And we show a much higher prevalence with those that have a PTSD diagnosis or even a trauma history. And again, this is very much one of those things that's dose effect. The more trauma that person has, the more likely there is going to be one of those substance use disorders or an addiction disorder. There are very much theories that folks are using these substances, and again, using it in a very broad term, to self-medicate to help alleviate the PTSD symptoms. And research really suggests that a combination of both psychotherapy and medication is the highest effective for both trauma and SUD. And really looking at combining the two and working at both of them simultaneously. Certainly in the past, when I trained, back when the dinosaurs roamed the earth, I was told you really have to treat that substance use disorder first. And research really is not showing that really the most effective combination is to take both the trauma and the substance use disorder and treat them simultaneously. Next slide, please. Here are some other resources that can be very helpful in terms of looking at trauma-informed care. Next slide. And again, you'll have an opportunity to get these slides with getting your CME. And these are QRS codes that you can scan, and they're videos that may be excellent for you to share with your patients. Next slide. Any questions? Thank you very much.
Great. Thank you, Dr. Parrish and Dr. Allen. Very informative. At this point, we will open it up for any questions that anyone may have. Please put in the Q&A box. As we're waiting, I'll just do a friendly reminder that basically you will receive an email link to complete an evaluation once this is all said and done, and a testation for the CME and CEU after hours. If you would like a copy of the slide deck, you can download a copy of the deck at the same site that you received the CME, CEU. All right, our first question, can we show the QR codes again? We sure can. Mackenzie, will you flip to the QR code slide?
I believe it's two back.
As that is coming on, we do have a question for you guys that came through. How about media coverage of traumatic events like 9/11?
I'll take a stab and then at that one. Yes, I do believe our news coverage does not do people any favors. Certainly, especially for those that have prolonged watching of the news. 9/11 had some incredibly traumatic events that were shown on national TV. I do not think that this does anyone any favors, and especially those with very traumatic past, that this can really be a potential trigger for them. Dr. Allen?
I agree with you completely.
Very good. Thank you, Dr. Parrish. Next, how can we bridge the gap between physical health providers and mental health providers?
I agree that this is one of those things that physical health and behavioral health really need to work at having those resources that they can refer to each other, that they trust each other, and have a good communication back and forth. This has absolutely been shown to be the best practice. And I think this is sort of one of those of finding each other in terms of each respective spaces. We're both in it together for both patients. We're both in there as a population health to really try and bridge that gap of getting to know who are the behavioral health providers for the primary care, and the behavioral health has the responsibility of really getting to know who are the primary care providers. And just opening up those communications so that you feel that you're on the same team and that it's not, I'm going to refer you now and it's a black hole, if that makes sense.
Yeah, I agree, Brooke. We all know about the importance of integrated care. For example, somebody going to a primary care office and instead of sending the person elsewhere for behavioral health needs, whether it's mental health or substance use, you're treating that person in the same setting with providers that they trust. And there's a higher likelihood that the people will actually follow through if they're within that same system, same building, same treatment plans, same medical record, same familiar providers. So I think that's significantly important. And as we know, people with really complex medical conditions who come back often have co-occurring mental health conditions that are exacerbating those medical conditions, and vice versa too. People with complex behavioral conditions have medical conditions, so we really need to address them both at the same time.
And I'll actually add a plug for collaborative care model, especially in terms of depression, and even trauma can work very nicely in a collaborative care model, which is slightly different than integrated. And it's based on really looking at screening in terms of depression, anxiety, or other, and following that database and using your behavioral health consultant um, to basically help guide the treatment. And often while you will have a master's level clinician integrated in the office, the consultant will more be away from seeing the patients, but can help guide both the master's level and the primary care provider using these databases. The other, obviously integrated care is unfortunately not the reality for most folks right now. And so again, I just would encourage the building of those relationships so that even if it's not in the same building, that you have that relationship with the physical health and behavioral health and vice versa. So that it is, and working on getting those communication streams, something that works for both of y'all, both for the physical health and behavioral health, be it phone conferences, uh, let's set aside 30 minutes every week to run through our shared patients, email, fax, whatever.
Great question, Linda. Great question. Next, we have, are there any thoughts about ketamine for PTSD?
I know there are some trials going on. I do not believe there have been as much in terms of double-blinded to put it as a solid recommendation. Tom, are you aware of the current research?
I know that there was some preliminary um, evidence that it could be helpful. I don't, I believe the FDA did not certify or approve ketamine as a treatment for PTSD. Um, I could be wrong. I know that just came out in the press.
Right.
So I think if anything, it's still considered experimental. I don't know that it has official indication for treatment of PTSD.
And I know probably the follow-up question, well, what happens with psilocybin, et cetera? And I do know that there's, again, preliminary stuff showing it could be helpful, but again, still considered experimental. And
Yeah,
unfortunately, for most of these, that's very hard to do the double-blind study. Most people fully recognize whether they've gotten real versus a placebo.
One of the added comments that was noted for ketamine treatments that because they're on the rise right now, they have met some PTSD clients who report the standard treatments of combined psychotherapy and meds are not helping them. And they are asking about ketamine. So good topic. Another question we have is when working with clients that have generations of trauma, such as African Americans regarding slavery, racism, discrimination, poverty, has this chronic trauma altered any chemical imbalances or other variables that impact their mental health? Because it seems that they are functioning in the US in chronic PTSD.
Absolutely. Historical trauma really counts as regular trauma. The microaggressions these populations see on a daily basis really can add up to, um, full-blown traumatic experiences. Furthermore, a lot of these populations, again, due to the poverty, et cetera, do have exposure again to acute trauma. So yes, they are experiencing chronic trauma on a daily basis, both currently and historically.
I know we are slowly running out of time. We'll allow for one more question. How can agencies and systems build in the time for this collaboration to happen for integrative healthcare?
There are some codes for collaborative care that can be used. I think as we recognize the value of um, such care, more of these codes we will see more of these codes. I think CMS is starting to recognize the importance of this. Tom.
Yeah, I agree. I mean, I think, the collaborative care codes have been around for a while. I think some of the biggest challenges are a lot of providers don't know how to use them. They don't know how to navigate some of the requirements of having that master's level behavioral health clinician on their team. But also elements of like using a registry and measurement-based care. All those are required, and so I think learning about the model and operationalizing it, and then learning how to bill for it, I think are some of the challenges. But it's a very effective model, and it can really work to provide that extra layer of behavioral health support in a primary care setting.
Great. Well, again, thank you, Dr. Parrish. Thank you, Dr. Allen. It's 9 o'clock on the dot. I appreciate everybody's questions. Thank you for attending and being with us this morning. Have a great day, everybody.
Thank you.
Thank you all.